their international rounds, so that after the Christmas break, and it's for me a great pleasure always to introduce Dr. Oechslin, who is one of the staff here in Toronto, the former director of the unit, and to talk about a topic that I think it is important. I think one of the things that determine how we talk about patients is how we communicate about their conditions, and Dr. Oechslin today is going to talk about unification of the medical language in the care of patients with fontan circulation. So, Erwin, thank you very much for agreeing to give this talk, and I'm looking forward to your lecture. Thank you.
Thank you very much, Rafa. Thank you very much for joining this meeting, the international rounds, and I'm welcoming all the friends around the globe. It's a great pleasure to speak about the medical language in the fontan care. And after this session, you should recognize there is an inconsistency of terms when we describe disease states, and this creates confusion and uncertainty in the entire community. And you should estimate the importance that the unified language is very, very important to facilitate the understanding, the consistency, and the interpretability of research and clinical experience. So we need to be on the same stage. If we're not on the same stage, we cannot communicate, we misunderstand each other. So at the end, you should also be able to formulate definitions for fontan-associated morbidities and disease states. I don't have any conflicts of interest to declare. So in the year 23, or in the 2000 era, we have gotten a little bit superficial and lazy regarding terms, how we use the words. And this comes from the cell phones and the media. Everything is fast, superficial. We don't pay attention to details. Grammar doesn't exist anymore. And this has an impact on our daily life, how we communicate, and even in the medical world. And I always tell, perception is not reality. And we need to adhere to the facts. And if we don't adhere to the facts and adhere to the real meaning of words, we misunderstand each other and we cannot communicate. We get confused and they're getting disorientated. So the fontan circulation is a very complex circulation, and the population is very, very heterogeneous. I don't need to tell you that. But the fontan circulation is a very complex mechanism. It's not only the ventricle. And there are a series of events which are very, very important. They are linked together. And if one element of this series of events is failing, the entire fontan circulation can fail. So it's not only the subaortic ventricle, it's also the systemic arterial bed with the vascular assistance, systemic venous bed, the preload is very important, the pulmonary vascular bed, the resistance in the lungs, the pressure in the left atrium, and everything is linked together. And there's a very sophisticated interplay and relationship among these different elements so that the fontan circulation can function. And these patients then have complications. They have arrhythmias. We apply vasodilators or vasoconstrictions. They're constrictors. They're volume loaded. They're collateral vessels. And then this very sophisticated network is distracted. And the final line, don't forget the lymphatic system, which also plays a very important role in fontan circulation, particularly patients who are failing. So that's a very, very complex mechanism. This is very nicely demonstrated also on this figure here, drafted by Dr. Laflamme and Dr. Roche and published in the Canadian Journal of Cardiology. You see the pulmonary vascular system in these patients, in FONTAN patients, elevated. They have a decreased cardiac output. And per definition, the central venous pressure is elevated in our patients. And this has a huge impact on all the organs in the FONTAN patients. And FONTAN patients, they have a multisystem disease, or I also call it the FONTAN disease, I guess, which very nicely describes the multisystem disorder in these patients. So we have many terms which need to be defined so that we are on the same stage and speak the same language. Because in publications, the different terms are differently used. There's a lack of definitions of the pulmonary vascular systems, or what's a failing FONTAN circulation, or what's the definition of FONTAN-associated liver disease, or how do we define diastolic dysfunction in these patients, or lymphatic system disorder. And all these definitions these terms have to be defined. So leaders of different scientific authorities and research groups found together 2 or 3 years ago and identified terms which should be defined so that we speak a unified language. And then there was a writing committee. There was a writing committee which then published these terms in the ESC Heart Failure Journal. So what did we use? We used the University of California, Los Angeles Rand Modified Delphi methodology to find definitions on 3 different terms. And each definition underwent at least 3 rounds of revisions to find then a final definition of each term. So what was the first step? The first step was to identify the terms which should be defined. And this was agreement among the representatives of these different scientific authorities or associations. Then they did an extensive literature review. They looked at the definitions which were used in these publications, and they came then up with a draft definition, the first definition, which was then sent to core committee members and asked for feedback. And then these committee members sent feedback. The feedback was incorporated in the new draft, the second version, the third version, and each definition underwent at least 2 rounds of surveys provided by experts around the globe. And definitions were included in the final draft if there was at least an 80% consensus after the second survey. And then there was a final meeting, a virtual meeting, a several-hour meeting, actually 2 sessions, where all the terms were reviewed, redefined, and the final document was drafted. And at least more than 90% consensus had to be reached. So I can show you, can you see the Word document here? So these are the different terms which
we can't, Erwin. Yeah, we see your presentation.
Oh, you see the presentation. So 15 definitions were defined, and then all definitions underwent a survey, 2 surveys, at least 2 surveys, and then, as I told you, at the final virtual meeting, these divisions, these terms were revised and then defined and the way to the final publications. So let's go to the first term, to the FONTAN circulatory failure. In the literature, there's an inconsistency of definitions. Everybody used different definitions. It's a very non-specific term to indicate a deterioration of the clinical status in these patients. Some publications use the composite endpoint to define Fontan failure, including death, listing for transplantation or transplantations. Others included the development of exercise intolerance, inability to carry out daily life activities, Fontan takedown, or heart failure symptoms, or comorbidities or complications, arrhythmias, thromboembolism, PLE, plastic bronchitis, edema, pleural effusion, liver dysfunction. So a potpourri, a menu of definitions and terms which were included in these different publications. You can imagine if you don't have a unified definition of a Fontan failure, you cannot compare the different studies, the different research projects, because everybody used different definitions. And it's not only the heart which is failing in these Fontan patients. Frequently, patients with a Fontan circulation have a completely normal ejection fraction of the left ventricle. But even though the ejection fraction is normal, the circulation is failing. Just remember the first slide. I told there's a series of events which are very important so that the Fontan circulation actually functions. Or they can have a compression of the pulmonary veins, which then has a very negative impact on the pulmonary venous pressure and the Fontan pressures. So it's not only the heart which is failing, the ventricular function, the systolic function, diastolic function, the valves play a very important role, the pulmonary vascular, the patient can have a pulmonary vein compression. Arrhythmias can also contribute to Fontan failure, Fontan-associated liver disease, and then the lymphatic systems. So there's a potpourri of etiologies contributing to Fontan failure. Heart or pump failure is very uncommon. That's a key message. And the use heart failure in Fontan patients should not be used. It's not the heart which is failing, it is the Fontan circulation which is failing, the entire circulation. And the correct term to describe a failing Fontan is Fontan circulatory failure or failing Fontan circulation. But the term heart failure should not be used in these patients. So what was the consensus of this expert group? So Fontan failure is a very broad, it's a non-specific term to describe the dysfunction of the Fontan circulation. And it affects then the patient's ability to carry out daily activities. And as I told, it is a potpourri of etiologies which can contribute to a failing Fontan circulation. The symptoms may be related to the classical heart failure symptoms, but the symptoms may also be related to a Fontan pathway obstruction, hypoxemia, end organ dysfunction like liver disease, PLE, or plastic bronchitis, mainly then in the pediatric population. So we also defined severe Fontan failure, and how did we define severe Fontan circulatory failure? This describes a composite of mortality, listing for heart transplantation, Fontan takedown, or a decision to initiate palliative care due to the lack of candidacy for heart transplantation. So the Fontan obstruction. This Fontan obstruction is probably frequently underestimated and even missed. They usually are seen or occur in the inferior limb of the Fontan baffles and the lateral tunnel. They can have stenosis in the pulmonary arteries, or they can even have a compression of the pulmonary arteries to enlarge the systemic arteries. And this has consequences. If you have an obstruction in the Fontan pathway, the central venous pressure is elevated. There is a more severe congestion of the liver, of the viscera, the exercise capacity is reduced, the preload is reduced, and the cardiac output is reduced. And this is a 35-year-old patient with a lateral tunnel fontan. And as you see here, there's a severe mismatch between the IVC here and the lateral fontan tunnel. But the pressure difference between the IVC and the pulmonary is only 1 millimeter of mercury. You may think, oh, that's not enough, that's nothing. But this makes a difference, this 1 millimeter difference. That's actually quite a gradient in the systemic venous circulation. So this patient underwent then stenting of this lateral tunnel baffle to have a more laminar flow. So how did we define a Fontan pathway obstruction? It is an anatomical or a functional narrowing, usually detected on cross-sectional imaging or in the cath lab. And it can be observed anywhere in the cave or pulmonary pathway. But this is important now. If you have a gradient 1 millimeter of mercury in the cath lab at rest, that's important, at rest. If you have a gradient as low as 1 millimeter of mercury, then this patient does have a Fontan pathway obstruction, and probably you should consider to improve this anatomical or functional narrowing to improve the Fontan flow. For the elevated pulmonary vascular resistance, how do we define the pulmonary vascular resistance in a Fontan patient or in Fontan patients? The pulmonary vascular resistance in Fontan patients is very complex, and it's already very difficult to assess. We need to know this inherent abnormality of the growth of these vessels, development and regulation, and there's no pulsatile flow. There's a laminar flow in the pulmonary vascular system, and this has an impact on the endothelial function, and then finally on the pulmonary vascular tone and pulmonary vascular resistance. And there are also regional maldistribution of the flow. And the vascular resistance can be very heterogeneous across the pulmonary vascular bed for many, many reasons. And the normal vasodilatory mechanism is suppressed because of endothelial dysfunction and because of the absence of the pulsatile flow. And last but not least, there's a huge impact of gravity on the venous return because we don't have a subpulmonary ventricle in a patient with Fontan circulation. And the central venous pressure is the power source of the pulmonary blood flow. So when the patient changes his or her body position from a supine position to an upright position, this may have a huge impact and does have a huge impact on the systemic venous return and the blood flow to the lungs. So just some precautions regarding assessment of the pulmonary vascular resistance. This is very challenging because there are multiple sources of pulmonary blood flow in these patients. We have aortopulmonary collateral vessels, we have venous malformations, and there's also a high prevalence of AV malformations in the lungs. So it's very, very complex to assess the pulmonary blood flow and then to calculate the pulmonary vascular resistance. Usually we use the FIC method, but the FIC method, as you can imagine now in these patients, has a lot of limitations. And we introduce some errors in the calculation of the pulmonary vascular resistance from the very beginning. The question is, what is a normal resistance, pulmonary vascular resistance at rest in a Fontan patients? And what is the pressure-flow relationship? We don't know that. There are a lot of questions. And what is the relationship between the resistance, pulmonary vascular resistance, and the clinical outcome and survival? So this is a study from the Mayo Clinic. They included Fontan patients, 261 patients, and they created two groups. group 1, patients with a poor hemodynamics, with a high pulmonary vascular resistance and low cardiac output, and then patients with a normal pulmonary vascular resistance and a normal cardiac output or cardiac index. And they defined Fontan failure as a composite endpoint of all-cause mortality or listing for the heart transplantation or initiation of palliative care. And at 5 years, the freedom from Fontan failure was significantly lower in group 1 in patients with a high pulmonary vascular resistance and low cardiac output, as opposed to those with a normal pulmonary vascular resistance defined as 2 Wood units, meter square, and patients with a normal cardiac index. So the combination of a pulmonary vascular index and low cardiac index is an independent risk factor for Fontan failure with a hazard ratio of 1.8. They did a more sophisticated analysis in this paper. They included 48 Fontan patients, but the patients did not have any obstruction or relevant valve disease. That's very, very important. And actually they created 4 groups. They took patients with a Fontan pressure normal, less than 15 or higher than 15, and the cardiac index defined as normal, higher than 2.5, and low as lower than 2.5 liter per minute per meter square. So if you now have these 4 groups, you see here, if you take patients with a normal cardiac index, these patients with a normal cardiac index had a significantly lower pulmonary vascular resistance index than those with a low cardiac index and a high Fontan pressure. And these patients with a normal cardiac index also had significantly lower systemic vascular resistance than those with a low cardiac index. It didn't matter if the Fontan pressure was normal or high. So if you do a Kaplan-Meier analysis for survival and stratify this analysis to the hemodynamic profile, what you see here, patients with a normal cardiac index but a high Fontan pressure had a significantly worse survival than the other 3 groups. So a normal cardiac index cannot be seen as reassuring for survival. It's also the Fontan pressure which is driving then the output. And based on the previous study, probably a pulmonary vascular resistance index of 2 Wood units meter square, that's probably so a cut-off point which is critical. And when the colleagues then did a logistic multivariate analysis, indeed a normal cardiac index at high Fontan pressure profile was an independent risk factor for mortality, as was heterotaxis syndrome or PLE. So based on these numbers, on these studies, and there are some other historical studies analyzing the impact of pulmonary vascular resistance on the outcome, the group came to the consensus that a PVR of higher than 2 indexed to Wood units is too high. But these numbers are mainly coming from the pediatric population. Remember, in adults, we don't use indexed Wood units, and we had a debate whether or not we should include Wood units indexed to body surface area or just Wood units, but we then came up with a recommendation for Wood units indexed to body surface area, because there are no real data, just analyzing what's the impact on survival or the outcome if you don't index the Wood units to the body surface area. So an elevated pulmonary vascular resistance was defined as a PVR higher than 2 Wood units indexed to body surface area. But the limitations, these are retrospective studies, and the studies are small. And as I told you, we don't have any data about non-indexed PVRs because in adults we don't use index PVR in adults. So the lymphatic system. The lymphatic system has been ignored for many, many years. And the role of the lymphatic system has been underestimated in FONTAN patients. But the lymphatic system is very, very important in the failing FONTAN circulation because they have an increased lymphatic production because of the high central venous pressure. The lymphatic vessels are dilated. Number two, there's a high central venous pressure. So here is the connection between the lymphatic duct to the central venous system, and per definition this has a negative impact on the pressure in the lymphatic system because of the high central venous pressure. Usually we should image, and we do image the lymphatic system best with T2 weighted MRI techniques, but this is challenging and some experience is needed. That's not a straightforward modality, but it's a very promising modality if you do it right. And if we image the lymphatic system, this gives us a much better understanding of the lymphatic anatomy in patients with a FONTAN circulation. And last but not least, then we can develop catheter-based lymphatic intervention. For instance, we can embolize abnormal channels, but again, this is some area of research, or this is only done in centers which have really expertise in doing these procedures. So how did we define lymphatic insufficiency? So any abnormality in the form of function of the lymphatic system resulting in a clinical disease. And this depends on the location of the lymphatic vessel decompression. And the lymphatic system, lymphatic insufficiency may manifest in different ways, depends where it occurs, depending on the location. Patients may develop PLE, they may ascites or pleural effusion, or plastic bronchitis. And plastic bronchitis is very rarely seen in adults. I have never seen an adult with a plastic bronchitis, but that's very common in the pediatric population. So portal hypertension. Patients with a FONTAN circulation do have portal venous hypertension by definition because of the increased central venous pressure, increased pressure in the IVC, 50 millimeters of mercury at least or higher. And this has an impact on the liver. The liver feels chronically congested over decades, and this has an impact on the architecture of the liver, has an impact on the lymphatic system, on the spleen, and then these patients can then develop FONTAN-associated liver disease, lymphatic insufficiency, PLEs, ascites, etc. So what types of portal hypertension do we have? There are three types: a prehepatic type, hepatic type, and posthepatic type. The prehepatic type is the pre-sinusal hypertension, and usually occurs in the portal vein, for instance, in portal vein thrombosis. The hepatic type, this type causes cirrhosis. That's usually the case in patients with alcohol abuse or hepatitis B and C. And there's the posthepatic type. And this is usually the case in patients with Chiari syndrome or patients with advanced heart disease, for instance, with chronic pericarditis, constrictive pericarditis, or in patients with high CVPs for any other reason, or the FONTAN patients. So patients with FONTAN circulation have a posthepatic venous hypertension, And usually this is a passive venous hypertension, usually without cirrhosis, but they can also have cirrhosis. And we always measure the hepatic venous wedge pressure in these Fontan patients. And the hepatic venous wedge pressure reflects the resistance of the vascular resistance across the vessels in the liver. And you know, the hepatic venous wedge pressure is usually very, very low, 0 or 1. This means the resistance across the liver is normal. This means the patients don't have cirrhosis, but as soon as the hepatic venous wedge pressure is elevated, then these patients can also have a hepatic cirrhosis, and then they have an increased vascular resistance. So portal hypertension is inherent in patients with a Fontan circulation because of the high central venous pressure. There may be an intrahepatic component, also hepatic cirrhosis, but that's very rare in patients with a Fontan circulation. Portal hypertension can be silent. Patients may not have any symptoms at all, but they may have symptoms, and portal hypertension is obviously present if they have a splenomegaly, develop ascites, varices, or thrombocytopenia. So PLE, we also have to define the PLE. PLE is the risk factor and defines the morbidity or mortality in patients with Fontan circulation. Has a negative impact on survival of these patients. And the causes are multiple causes and multifactorial. We understand some causes by the PLE, and we don't understand the whole story of PLE. So how did you define the diagnosis of PLE? So it's a state of increased enteric protein loss. And this is measured by alpha-fetoprotein, antitrypsin. Alpha-1 antitrypsin. You can just measure this in one spot or during 24 hours. And if the alpha-1 antitrypsin clearance is higher than 72 milliliters per 24 hours without diarrhea, then you have PLE. But if the patient does have diarrhea, then the alpha-1 antitrypsin clearance is then defined as being higher than 56 milliliters per 24 hours. So how does PLE present? It can be subclinical or clinical. If you have a subclinical presentation, then usually these patients just have a low albumin level or a low protein level. But if the patients do have clinically evident PLE, then they have symptoms per definition, which include edema, abdominal distension, discomfort, diarrhea. They have effusions, ascites, pleural effusions, or even pericardial effusion. So that's the definition of the clinical presentation of PLE. Now, Fontan-associated liver disease. That's also a very complex and the topic and the topic in itself. Again, central venous pressures are important, which contributes to Fontan-associated liver disease. Liver fibrosis is very, very common in Fontan patients, and risk factors are older age, times in Fontan circulation, and even perioperative insults or complications. In patients with a Fontan circulation or Fontan-associated liver disease, we need to avoid modifying factors which can lead to a progression of Fontan-associated liver disease. They should avoid drinking alcohol, we should avoid hepatotoxic medications or vaccination, or they should be vaccinated against hepatitis. We screen patients with we screen patients for FONTAN-associated liver disease in the pediatric population because they are younger, they have a shorter history. The screening is sort of every 3 to 5 years, but in adults, we screen these patients every year to find any symptoms or signs or findings of FONTAN-associated liver disease. And this can be done by abdominal ultrasound, MRI, or CT to evaluate for liver lesions. So how is FONTAN-associated liver disease defined? So this is a very broad spectrum of liver disease, and the consequences are attributable to the Fontan hemodynamics. So FONTAN-associated liver disease can just include hepatic fibrosis, just fibrosis, or cirrhosis, which can be compensated or decompensated, or nodular hyperplasia, or some laboratory evidence of hepatic injury or impaired synthetic function of the liver, or hepatic cellular carcinoma. So it's a very broad spectrum, very broad spectrum, which is included in FONTAN-associated liver disease, just from a simple hepatic fibrosis or some abnormal liver enzyme function. And the worst end of the spectrum is then the hepatocellular carcinoma. Liver cirrhosis, that's a more specific term than Fontan-associated liver disease. This is a late stage of progressive hepatic fibrosis. And per definition, the hepatic architecture is distorted. And we have regenerative nodules if we have liver cirrhosis. And patients can have an early stage of liver cirrhosis, then usually synthetic function of the liver is preserved. But if the liver cirrhosis is in a late stage, then we have an impaired function, impaired synthetic function of the liver. So how do we diagnose liver cirrhosis? That's the key, and that's important for studies when we do research. How do we define liver cirrhosis? The reference diagnostic method is the biopsy. It's a histological diagnosis. Imaging can just suggest a liver cirrhosis. There may be liver cirrhosis, but if you want to prove liver cirrhosis, you have to do a biopsy. That's a key message. And the histological diagnosis defined by a bridging fibrosis and nodular regeneration. And again, the radiologist can just suggest cirrhosis if you have a nodular contour, features of portal hypertension, including splenomegaly, ascites, and collateral vessels. There are also clinical features which can support the presence of cirrhosis of the liver. This includes vasodilations, when you examine the patient, spider-naive pulmonary edema, or portal hypertension, which leads to varicose bleeding, ascites, portosystemic shunting, and encephalopathy. And there are also laboratory findings which can suggest liver cirrhosis. If the liver enzymes are elevated, the platelet count is low, if the spleen is enlarged, and if there's evidence of a low albumin in the absence of PLE. So there's a big debate how do we define exercise performance in Fontan patients. Reduced exercise performance is very, very common in patients with a Fontan circulation when we do a cardiopulmonary study, and the mean peak VO2 ranges between 50 to 65% predicted. The VO2 max is a predictor for survival. There are many reasons for a low exercise performance, which you are aware of. They have a decreased cardiac output, blunted or inadequate heart rate response to exercise because of sinus node dysfunction, or they are on medications, antiarrhythmic drugs, etc. So how did we define a low exercise performance? So if the peak VO2 is below 50% of the predicted value for the general non-affected population, equal to age, sex, and body size, also peak VO2 lower than 50% predicted. High performance, if you have a peak VO2 of higher than 80%, then this FONTAN patient has a very, very good performance, exercise capacity. How do we define systolic ventricular dysfunction in these patients? That's a big matter of debate. The ejection fraction is frequently used. They have an intrinsic ventricular dysfunction, systolic dysfunction, and diastolic dysfunction. And it's also related to the altered preload. We can assess the function by echocardiography, but a quantitative evaluation is very challenging because the geometry of the ventricle is very, very complex. Usually you cannot apply the Simpson rule to these ventricles. We do it every day, but there are some limitations and we need to be aware of these limitations. So usually we do just a qualitative assessment of the ventricular function. The MRI is the reference method. With an MRI, you can accurately measure the ejection fraction of a single ventricle. So how did we define systolic dysfunction? The presence of a single ventricle ejection fraction of less than 50%. So that's what we defined. If the ejection fraction is less than 50%, then the patient has a systolic dysfunction. Now, diastolic dysfunction, that's very common, and every FONTAN patient does have a diastolic dysfunction. And assessment of diastolic dysfunction is very, very, very challenging, and it cannot be done by echocardiography. You cannot apply the standard diastolic indices we are using for a biventricular circulation. We cannot apply these indices to FONTAN patients. That's very, very important. So if you want to assess the diastolic dysfunction, we need to directly measure the ventricular diastolic pressure. That's the gold standard. This means we need to do a diagnostic heart cath. And in several studies, they used the cath of an end diastolic pressure of higher than 10 to 12 millimeters of mercury. So we came up with the following definition. If the end diastolic pressure or wedge pressure is 12 millimeters of mercury or higher at rest, or higher than 15 millimeters of mercury after rapid fluid challenge, then you have a suspicion or suggestion of diastolic dysfunction of this patient. Bradycardia, so that's in adults, we defined a heart rate of less than 50%. So that's also, I think, an important definition. If we define bradycardia in a research patient, what's bradycardia? Is it 60 or 50 or 60 beats per minute, or is it 40 beats per minute, or is it 70 beats per minute? But we came up with a definition of less than 50 beats per minute in adults. But this may change in a few years when we then have more research and more evidence how to define bradycardia in a FONTAN patient. Sustained atrial or ventricular tachycardia was defined as a heart rate of 100 beats per minute in adults, or less than 30 seconds if the tachycardia is associated with a hemodynamic instability, or any duration if the arrhythmia, if the atrial tachycardia, ventricular tachycardia needed treatment. So just to summarize, this is an area which will change. These are the definitions we just provided or put together in the year 2021. But in 5 years, when we have more evidence, then these definitions may change. But that's what we have at the moment. But these terms and definitions just represent the consensus of a panel of experts. It's a consensus, and it's a recommendation we should use so that we can communicate with each other. It's also important that we can compare different studies so that we use the same definitions in clinical studies. But if everybody uses different definitions, we cannot compare different studies or registries or clinical trials. So a common language is very, very important, critical for this reason. And if anybody is interested in a very comprehensive overview on the review of papers in patients with a spontan circulation, univentricular circulation, then I recommend you this issue in the Canadian Journal of Cardiology. It's a potpourri of excellent articles addressing issues in patients with a spontan circulation. Thank you very much for your attention.
Thank you, Erwin, for the excellent talk and review of the topic. So if anybody has any questions, please just write them in the chat or feel free to unmute your microphones and ask directly the questions. So I have some, so I